think the important thing from that is that a lot of those resources that Susie spoke about are free, and I think that's the most important thing, the sharing of expertise and the fact that it's readily available to all of us here. The next two speakers are Ruth Drimer and Rachel Jones, who are nurse specialists, and they have a special interest in ADHD. Their field of expertise is neurofibromatosis. I think all I remember from med school is there's two types. One type's very rare, one type's not as rare, and I'm sure you're going to tell us more about that as well. Dr. Iqbal, during the break, was asking me about whether ADHD can be affected by direct insults to the brain, and I think this is one such example of CNS insults that can actually contribute to the development of ADHD. So, hold on.
This is my fight song. Take
Hello, as just been introduced, my name is Ruth. I'm a specialist nurse for neurofibromatosis 1. Just to clarify, we both work in neurofibromatosis 1, not neurofibromatosis 2, which is a totally separate condition, and we don't have any expertise in that area. So I work in Yorkshire and Humber region, and this is my colleague Rachel Jones, who covers the North East in Cumbria. Today we'd like to talk to you about the genetic condition neurofibromatosis 1, or NF1, which is a lot easier to say, and the effects that it can have on learning and behaviour. So just to let you know what we'll be talking about today, we'll start with what is NF1, explain who we are and what our role is, and let you know why we felt it was important to present today. We'll then talk about NF1 and the effects it can have on learning behaviour, more specifically ADHD, ADD, the links with NF1 and autism, sorry, I can hear myself, and other comorbidities. We'd then like to explain the importance of collaborative working to us and to our patients and innovative practice, and then of course we'll be happy to take any of your questions. So what is NF1? NF1 is a genetic condition which can either run in families or occur as a sporadic mutation. To explain NF1, we first need to understand the function of the NF1 gene. The NF1 gene provides the instructions for making a protein called neurofibromin, and this protein is produced in many types of cells, including nerve cells. Neurofibrin acts as a tumour suppressor, and suppressors normally prevent cells from growing, dividing too rapidly or in an uncontrolled way. The protein appears to prevent cell overgrowth by turning off another protein called RAS that stimulates cell growth and division. Move that across. So here we've got on this slide our diagnostic criteria, which was first established in 1987, but this is our most recent and up-to-date version. So I'm going to illustrate some of these features in some of the slides that follow. NF1 is characterised by two or more of these following features. So as Ruth was saying, it is a genetic condition, so a first degree relative with NF1 is one of the clinical features that we look for. Caffeole patches, 6 or more of, which I can show you on this slide here. We expect to see 99% of individuals with NF1 to have these by the age of 3. Now these two pictures show variations in the light and darkness of these patches, and also they vary in size as well. One red flag marker that we do look for are very large caffeole patches, especially if they're covered in hair, because this is an indication that there may be a plexiform involvement, which I'll discuss in a second. So also on the list we've got skin fold freckling, especially, sorry, I'll just get to there we go, in this photo here, especially axillary freckling or groin freckling, but we do sometimes see this in freckling on the upper eyelid and also underneath the breast and underneath at the base of the neck as well. We also see benign peripheral nerve sheath tumours, or more commonly known as neurofibromas. Now we've got two photos here. The one on the left shows cutaneous neurofibromas, and these are just little bobbly lesions that sit on top of the skin. The one on the right are the subcutaneous neurofibromas. Now it is thought that these are attached to the nerves, and these can cause pain in the individuals. We expect to see a significant proportion of people having these neurofibromas by adolescence. So also, I mentioned earlier plexiform neurofibromas, and these are diffuse tumours that actually grow along the length of the nerve. These can be incredibly painful. Dependent on the position of these in the body as well, they can cause a deficit in quite a significant proportion of people who have them. They also have 10% risk of malignant change, so these are things that we really do look out for quite closely. Sorry, going too far. Leash nodules, I have that on this photo here. So these are dome-shaped hamartomas that occur on the iris, and we expect to see 2 or more for a diagnosis. And these were first identified in 1937 by a gentleman called Carl Leash. So also on our clinical criteria, we have optic pathway gliomas, which are growths on the optic nerve at the back of the eye. These are in the main indolent, but 5 to 7% of people, mainly between the ages of 0 to 7, will display symptoms. And if visual loss is one of the symptoms, then we do tend to see some children starting on chemotherapy for this. Bony dysplasia of the sphenoid wing is another feature on the diagnostic criteria, and this is a defective formation of the skull where the temporal lobe is actually pushed forward into the orbit. And finally, we've got bowing of the long bones, mainly the tibia, and that completes the diagnostic criteria. Part of the reason I've gone into this in quite a bit of detail is just to make people aware of this if you do have a child or an adult indeed walk through your door with neurofibromatosis type 1. So the complications are variable, they're unpredictable, and they're also widespread. In addition to these features on this clinical criteria, we do tend to see other complications such as hypertension, disfigurement and malignancy. And also, and the reason we're here today to talk about it, quite extensive learning and behavioural difficulties as well.
Okay, as well as working as specialist nurses and for the complex service based in Manchester, Rachel and I also work as specialist advisors for the Neuro Foundation. Our work includes giving people the time to talk about NF1 and what it means to them, supporting those that are newly diagnosed, providing ongoing contact if and when needed, giving accurate and up-to-date information. I'm sure all of you know that many patients go on the internet and there's so much out there that just isn't true. We also inform about other organisations that may be able to be of help. We act as a contact point for health, education and social services. And we give guidance on educational problems, and that includes going into schools and talking to teachers. We also run our own clinics, but we're happy to accompany patients to other clinics where appropriate. So as you can see, there are several of us around the country, but also large areas of the country left totally uncovered. Susan and Rachel work in the North East and Cumbria. Caroline Smith works in the Midlands. Helen Tompkins in the South West. Caroline Redman, the South of England, and myself covering Yorkshire and Humber. Communication is vital in our role, so we put our contact details up there, but we've also put the contact details of Rosemary Ashton, and she runs the telephone helpline for the Neuro Foundation on a Tuesday and Wednesday and has a wealth of experience and can give you lots of information.
So why are we here talking at this ADHD conference today? Dependent on which study that you look at, 30 to 60% of children and adults with NF1 will have some kind of learning difficulty. Cognitive impairment in NF1 is characterised by low average IQ. Mental retardation is 3 times that of the general population, but I'd just like to stress that most of these individuals with NF1 do fall within the average range, albeit the low average range. We also see specific learning problems, which you can see on this slide here. I won't read them all out, but they're quite extensive, and also behavioural difficulties as well. We find that males and females are affected equally, but from individual to individual there are huge variations, both in the learning problems, the behavioural problems, and also the health complications that we see. So as you can see, the complications can affect people through visual, spatial difficulties. Memory, it's more short-term memory than long-term memory problems that we see, and also speech and language. So this means that children at school are quite affected in terms of their progress in reading, writing and maths. In addition to these areas, we also find that children have, and adults as well, have poor planning, time management and organisational skills. Fine and gross motor skills are also an issue, and incoordination and joint laxity affect about 20 to 30% of these children. The behavioural problems manifest as ADHD, although it's mainly ADD, but Ruth's going to expand upon that in a